Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, a physiotherapist, the host of Paincast, and an executive member of the Pain Science Division. I have always used the opportunity of attending a conference to do short interviews with conference attendees. To me, this is a great way to have more voices on Paincast. If you've been following Paincast, you would have seen episodes coming out of the World Physiotherapy Congress last year in 2025 and Canadian Physiotherapy conferences in 2023 and 2024. This year, I attended the Canadian Pain Society conference in Quebec City, and I'm excited to bring you interviews with 4 incredible individuals discussing the role of a pain physician, the importance of patient advocates, technology and AI for pain management, and pain care research. Before we start, as a reminder, Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in each episode are of individual guests, do not constitute medical advice, and do not represent the views of the Pain Science Division or the Canadian Physiotherapy Association. Enjoy the episode. I have the pleasure to meet and chat with Dr. Andrea Furlan. Can you introduce yourself, the many things that you're doing, where you're based, and how are you connected with the pain world?
Thank you so much, Tiffany, for inviting me to be on your Paincast. This is a great initiative. Yes, I am a physician, specialist in physical medicine, rehabilitation, physiatry, and I work in a pain clinic at Toronto Rehab, UHN in Toronto, which is one of the clinics part of TAPMI, the Toronto Academic Pain Medicine Institute. And I'm also a professor of medicine at the University of Toronto, so I teach students, residents, fellows, and I'm also a senior scientist at UHN in the KITE Institute. So that's about me.
You do a lot of things. I think so. Why are you so passionate in this area, and what interests you about pain medicine?
So my career started when I was in medical school. I did my medical school in residency in Brazil. And when I was in the internship in medical school there, I didn't know what specialty I wanted to follow. I knew I liked things like clinical areas, but I did not know exactly what to do. And I remember one day we admitted one person, a female patient, probably in her 50s. We admitted her from the emergency department. I was rotating in the general internal medicine ward. She had pain all over her body, and she showed up in emergency, and so we admitted her to investigate. And we ordered all kinds of blood tests and imaging studies. This is more than 35 years ago, okay? So there was no MRIs at that time. But we didn't find anything wrong with her, like her body was okay, but you couldn't touch her. You couldn't even touch her skin because she screamed of pain and nobody knew what she had. So I remember my attending asked a consult from a physiatrist, and here comes a physiatrist to do a consult. He came with acupuncture needles. He then stick some needles on her and started talking to me about physiatry. If I knew what it was, I had never heard about. This was a specialty of medicine. 20 minutes later, when he removed the needles, she was pain-free. And we discharged her the next day. And then I said, oh my God, what is that? Dr. Vu, he became my friend and my mentor in Brazil. And I became an acupuncturist because of that. So I decided to do physiatry, because the answer he gave to me was the best answer. He said, Andrea, the needles, and again, this is 1990, 36 years ago. He said to me, Andrea, we now know that the brain produces endorphins, and the needles just stimulated her brainstem to open that pharmacy and release a lot of endorphins. But those endorphins will disappear from her body in about a week, and she'll be back to what she was before. She has fibromyalgia, and she needs a whole multidisciplinary treatment. And I said, oh my God, how come that nobody knows about this? And in the general internal medicine field, nobody knew about this. So I decided at that moment I wanted to study pain. And then I did physiatry. And it's still 35 years later, a lot of doctors don't know that we have an inner pharmacy in our brain, that we can modify our brain and treat pain with our own endogenous opioids, endogenous cannabinoids, endogenous dopamine, serotonin. So that's why I'm doing what I'm doing.
That's a very cool story. Do you
Yeah.
still do acupuncture?
Yeah. In Brazil, I became an acupuncturist and physiatrist, and I was even teaching in the course for physicians acupuncture. Here, when I came to Canada, I did my PhD in clinical epidemiology. I did a lot of meta-analysis, systematic reviews, Cochrane reviews, and guidelines. So then I stopped doing acupuncture. Now, with my patients, I recommend acupuncture as a temporary measure. I tell them if you have means to afford, because it's expensive and it's temporary. Like we know, it helps your body to release endorphins. It's temporary. You will back to what you were before. So I tell them maybe it's better instead of using a pill, that a pill only lasts, 6 hours, 12 hours, at most 24 hours. Acupuncture will help you to be pain-free, or at least a lot better for a couple of times, but don't expect that acupuncture will improve all of your pains forever, although that's also possible sometimes. I have some stories that people got better, including my husband, who had chronic migraines, and he never allowed me to stick needles on him because he didn't believe that those were real medicine. And one day he was having a migraine attack. He was so desperate that he allowed me to stick needles on him. And since that time, he never had another migraine attack.
No way.
Yeah.
Oh, so with your clinical practice, what kind of patients do you see?
Yeah, I see. Because I'm a physiatrist, people send to me a lot of people who have musculoskeletal pain. These are neck pain, shoulder, low back, knees, hips. But I also see people with fibromyalgia. I see people with complex regional pain syndrome. I see people with neuropathic pains. In my clinic, I don't see people with migraines or pelvic pain or abdominal pain, those kind of things. I don't consider myself a specialist in those areas. But a lot of people that have musculoskeletal pain, they also have those comorbidities, so they end up being in the package, in the mix of everything. But most of my patients are musculoskeletal.
So I think maybe a part of our audience, pain physiatry might be something new to them. Can you explain the unique role physiatrists can play in a person's pain management as opposed to, let's say, for example, physiotherapy, occupational therapy, other types of therapy?
Yeah, physiatry is a specialty that not a lot of people heard about it. We have 300 physiatrists in Canada, the same number of rheumatologists, but physiatry is a specialty, is a medical specialty. We do 5 years of residency in Canada, and it is the physician that specializes in a person with a physical disability, like paraplegics, quadriplegics, amputees, people who have stroke, and they need a rehabilitation program. And the physician is part of that multidisciplinary team that will rehabilitate the person. Because part of our training, like day one of physiatry residency, you are already embedded in a multidisciplinary team because nobody can do rehabilitation alone. So I think that lends really well for pain rehabilitation, because chronic pain, it's really hard for only one profession to see the whole picture. And a physiatry, because of our training, is embedded in a multidisciplinary interprofessional team. We do this really well working with other professions. So the other professions that we have in our pain clinic at Toronto Rehab, we have nurse, she's a nurse educator. We have a pharmacist, and we have physiotherapy, occupational therapy, social worker, and kinesiologist. So we're really seeing the person from multiple perspectives.
Would you say pain physiatry is sort of like a coordinator of the rehab team, or what's
Yeah.
its position within that?
No, it's not the coordinator. We are one member of the team.
One member.
We are one member of the team. Everybody has the same voice. Each one of us, we are professionals in our own profession. So each one of us, we have our scope of practice. And the goal is that in a team, everybody will be acting and doing things at the best of their scope of practice. So the nurse in our team, we want her to be the best nurse in her scope of practice. So she knows everything about all the educational resources, all the community resources that I don't know. So I need a nurse, I need someone in my team that knows everything that is happening in the community, all the workshops, where we can send our patients, where they can access this and that, and coordination of the referrals. I can't do that. And patients with chronic pain, they're very complex. They bring a lot of complexities that are not just the physical pain, they come with emotional disturbances, sleep disturbances. They come with a lot of social deprivation. They are isolated. Some people stopped living because of chronic pain. So, how do you activate that person? And we use the same philosophy that we use to rehabilitate someone who became quadriplegic. Like when someone has a quadriplegia, if they broke their neck and they can't walk anymore, how can you rehabilitate that person? And you probably have seen quadriplegics who are doing much more than I am doing. Like they're traveling all over the world, they are professionals, sometimes they are in sports, they are competing in the Paralympics. And I tell, you are better than I am. You have much more function and much more purpose in your life. You are happy. So a disability doesn't mean the person needs to stop living, but we see a lot with chronic pain.
So what do you do specifically in this team setting?
Yeah, it starts with a consult with a diagnosis, and then depending on what the person comes with, they have more like a need to be more physically active because they are very fearful of pain. Like fear of pain is paralyzing. I find this is so common. In most of my patients with chronic pain, like I'm talking about people who have pain for 10, 20, 40 years, their musculoskeletal system is already okay. It's healed. Whatever they had in the beginning, it's healed. Their injury, their trauma, their accident, it's gone. But during those years, like 10, 20 years, they have become like a prisoner of their own fears. And they come with a list of, I can't do this, I can't do that, I can't do this. So we send them to this program of rehabilitation to lose the fear, to believe in their body, to change their mindset that yes, you can dance. How many times I prescribe dance to my patients? A lot. Why dance? Because I have a lot of patients that they like dancing, they love dancing, and they're not dancing. And I tell them, you can dance. Oh, really, doctor? Yes. Because dance is a great cardio exercise. It's great for socializing. It's fun. It releases endorphins, endocannabinoids, dopamine, serotonin. Has so many advantages. It's a complete exercise. So, for example, and then they say, no, I can't dance because I hurt or whatever. So, okay, so we'll help you to take the steps. What do you need to dance? Or you need, maybe a little bit more training cardiovascular. So you need to train your lungs and your heart. And let's start with that. Let's start with some aerobics. But then you don't have balance. So now let's do some balance exercise. And then by the time that they are dancing, they come to me and they say, I don't need you anymore, Dr. Furlan. I am already rehabilitated. Dancing is an example, but anything that they like.
So what are the challenges you face in your work then?
Yeah, I would say coming back to that patient that I saw 35 years ago, that at that point we knew that the brain has such an enormous capacity to help in pain. I'm not here to talk about acupuncture. I'm talking about the mechanism behind that, what I saw. I saw the brain being able to heal itself, to heal the body. And I'm frustrated that 35 years later, we are still not using the brain in that capacity. What frustrates me a lot is that patients resistant to the message that I want to give them, that the moment I use the word brain, this doctor doesn't believe me. Oh, I had a patient telling me this last week. I saw this patient, first time I'm seeing her. I think she has 50 years of pain, 50 or 60 years of pain, and nothing wrong with her body, but she really believes that because she has pain all over her body. She really believes that she has 35 different diagnoses. No, I have a shoulder tendinitis. I have an impingement on the left. I have frozen shoulder on the right. And then I have a facet joint on my neck. I have a lumbar spinal stenosis. And I said, 35 different diagnoses? You were the most unlucky person in the world, or it's your brain that is carrying all this weight. And she had a lot of trauma in her life, a lot of psychological trauma, a lot of anxiety that she acknowledged. She told me, yes, I have trauma, I have anxiety, but they have nothing to do with my pain. They're not the cause of my pain. I said, well, but your brain is in hypervigilance. The moment I used the word brain, she looked at me, she said, oh, are you telling me that my pain is in my brain? It's not, it's in my body. So that resistance frustrates me, because I know if we retrain how she thinks and she sees herself, she would be able to do more. But in that situation that they want to believe that their whole body is broken and damaged, what can I do? I'm not going to send her to 100 sessions of physiotherapy to treat her body, because she doesn't need that. So my colleagues also frustrate me, because she received, it's not her fault. She saw more than, how many specialists and physiotherapists, doctors, chiropractors who told her these messages that they were seeing one part. They were seeing her left shoulder. They examined her left shoulder and said, oh, you have an impingement here. That's why you have pain in the shoulder. But they didn't see the whole picture.
Yes.
All of her 6 years of pain and trauma and anxieties, reinforcing each professional that looks at her and reinforces your body is broken here and here and here and here and here. It's really hard for me to come and try to retrain her brain.
Yeah. So what you're trying to do is connecting the dots.
I connect
Whereas
the dots.
healthcare is very fragmented as of now in our system. What do you ultimately hope to achieve in the work that you do?
I think knowledge is power. What I'm trying to do lately with a lot of projects that I have, I think if we can disseminate knowledge and teach people, teaching the patients, teaching the healthcare providers, the policymakers, the society in general, everybody can be talking the same language and understanding pain better. I think there's a lack of understanding of what pain is and what pain is not. Acute pain, yes, acute pain is different. It can be like a something that is broken in your body, and you go and fix it, and that pain goes away. But in chronic pain, there is very little that can be fixed, because it's now become a neurological disorder. It's a disorder of the pain system itself. So I'm using a lot of education. I use Project ECHO, which is this collaborative network for healthcare professionals to learn about pain. So they come, every healthcare professional is invited. We are funded by the Ontario Ministry of Health in Ontario, but there are many ECHOs, chronic pain across Canada, that they can join, and they present complex cases that they have of chronic pain, and the whole community will discuss that case. So that's a way of disseminating knowledge to healthcare professionals. I also wrote books for patients with chronic pain, hoping that if they read the book, they will learn more about chronic pain. I also post a lot of content on social media. I have a channel on YouTube that I also explain the neuroscience of pain. I explain the concepts and the importance of exercises and moving and losing the fear of pain, hoping that, people will watch some of my videos and have an aha moment and say, okay, maybe there's something that I can do and change the course of my life, because a lot of people are stuck in their life and they don't see a way out. They don't see a way that they can change and change the way we see medications. I'm not against medications for pain. I do prescribe medications, painkillers, anticonvulsants, antidepressants, but it's a small proportion of patients that need those. And sometimes they need just for temporary, so for a period of time, just to regulate their sleep, their depression, their pain. They don't need that forever. And research, creating new interventions, testing new ways of retraining the pain system with pain neuroscience education, pain reprocessing therapy. I think we need to innovate and bring new things that are evidence-based.
Thank you so much for spending time and sharing your journey and the passion you have. I'll link some of these in the show notes so you can have access to join Project Echo. I'm a part of it, and follow Dr. Furlan on social media.
Thank you so much. It was a pleasure talking to you today.
Here I have the pleasure and honor to talk to Lynn Cooper. You're a powerhouse. You do a lot of things, and I'm very impressed all that you do. Can you introduce yourself to our audience, where you're based, and how you're connected to the pain world?
Oh, wow. I'm Lynn Cooper. I live in Kitchener, Ontario, and I'm connected all across Canada with different initiatives related to pain education, pain research, pain management. I am employed part-time with the Ottawa Hospital Research Institute, and specifically with the Power Over Pain portal. And I'm just so glad to be involved with it. I'm also employed part-time with the School of Rehabilitation, working on physiotherapy projects as well at Queen's University. And I'm really thrilled to tell you that I am a member of the Chronic Pain and Opioid Stewardship Hub of ECHO, Ontario. I get to work with health professionals from all disciplines and researchers as well to help clinicians to understand how to manage very challenging and difficult patients.
Mm-hmm. And so your role in all of these involvements would be as a person with lived experience.
Yes, isn't that amazing? I am really trained in environmental studies, urban and regional planning. That's what I went to the University of Waterloo to learn and to be. And I was in one of those pay the rent jobs, where I went to work one day and I sustained a preventable workplace injury. And from that, I developed chronic pain. And the rest, as they say, is history. I wanted to be useful to society. I wanted to help others whose voices were silenced with pain because of the climate within healthcare at the time, where you were a patient who received pain care or received care, and you really weren't terribly involved in it. It was more like you were a passive patient. And I quickly learned that that was not what needed to happen. We, as people living with the pain, need to become knowledgeable about our pain, and we need to become engaged in our pain care and working in collaboration with our healthcare providers to get the best possible outcomes we can have for our pain and pain management.
Yeah. So throughout this conference, we have been hearing this being emphasized, nothing for us without us.
That's correct.
Us being people with lived experience. Can you just spell it out for the audience? Why is it so important to have people with lived experience involved in pain advocacy, advancing in pain management and pain research?
It is integral to have people with lived experience involved in everything, in policy setting, as you said, research, in developing pain management tools, in advocacy about it. We live with pain to some degree all day, every week, every month, which spans into, for me, almost 40 years since that workplace accident. We know how pain impacts our body. We have insights into what can help make that living with pain easier, from what healthcare delivery looks like, from what mental health and substance use resources and advice and pain resources, sleep resources need to look like, and how they can best be delivered so that we can consume them, learn from them, and then integrate what we've learned into our lives. For instance, I talk about if we're talking about resources and resource presentation, I talk about having a pain brain. That's not being demeaning to me. It's now a reality where because the pain is taking up space in my being, and it can interfere with memory sometimes and what I absorb from the world around me. Any resource that I'm going to interact with has to be simplified, made simple with not as much text, with certain colors within the presentation, with certain size fonts, with very precise ways of bringing information forward so that my pain brain can adjust to it and can absorb it so that I can use it. That's an example. I remember, Tiffany, one time I was at a CPS conference and this incredible pain clinician and scientist came up to me and he said, "You know, Lynn, we are holding neuropathic pain meeting and we want to do some research in neuropathic pain. And so I just wanted to tell you we're doing this. And I'm assuming that the outcome that we should be looking at only is the level of pain that people would feel from nerve damage pain." And he was a very tall man, Tiffany, and I looked up at him and I said, "Yes, pain, the level of pain, the intensity of pain is important. But dear researcher, I would like a good night's sleep. And I would like to have ways of helping me with mood, to improve my mood. And I would like to know what diet might be more helpful to reduce pain levels." And so many more things, to the point where we were standing and we sat down. And we continued our conversation about the outcomes that are important to me as a person with lived experience. And this researcher was enthralled by the number of outcomes that he had not thought about. So within research, we can help to define research questions that are more meaningful to the outcomes that might take place in pain services to people living with pain or pain care. We can define what some of the parameters would be and what some of the outcomes that we're looking for. So we have a lot to offer in that way. We can also participate in helping to run some of these studies. And when our incredible scientists get their results back, either from quantitative or qualitative research, we can help to interpret what the results are showing and thereby point to further gaps in research that we would like to see happen, or fine-tune the ways that the research is brought to the world, including co-presenting. Another thing, may I share, within the awareness building and the advocacy, I had many experiences where I was speaking with members of parliament, MLAs, and MPPs. And I found that at times my perspectives and my voice needed to be legitimized by the doctor at my side, whose perspectives needed to be legitimized by me. And so when I was more heavily involved in advocacy and awareness building, by the way, I do that every day, but within specific campaigns that I participated in, say, with the Canadian Pain Society, we would have a person with lived experience, a clinician, and a researcher go together to give presentations and then tell how bad it was, what we needed, and what we could do, and how they could help by getting us money to fund some of the work that needed to be done to reach our end goals. So one perspective to talk about pain, its management, and how we need to have supports to improve and create evolving health systems related to improved pain care is not enough. We need at least the three perspectives. And if we can even bring in a policy expert or an economist expert to talk about how we can balance the costs, the benefits of all of this, really can put things in perspective for those people who hold the purse strings, who can give us the attention that's needed and the money. So I liken this to, in the advocacy world, that no one management option for us as people with lived experience is sufficient. We need to have many options, many tools available to us. So that may include medication of different levels. And on top of that, the person themselves having a knowledge of what type of pain they live with and different strategies that they can learn, like mindfulness, their diet, exercise, different coping strategies that we can use, like planning our lives, remembering that we can have a life in spite of pain, pacing in order to make that happen, and prioritizing things when our energy levels are low. If we learn all those things, combine it with medication, then our interaction with our different healthcare providers who can help us. Then if we add to that the social aspects that are so important, keeping our social connections, and also getting involved in self-help organizations where we can avail ourselves of support groups, self-help groups that are run in a positive, evidence-informed manner. And the list goes on. Getting and receiving a hug, doing something every day we enjoy. So both of these pursuits in the personal living and managing persistent pain, and also the advocacy, awareness building, and building support require more than one perspective, more than one action, more than one voice and perspective.
Would you be able to share some of the challenges you face in this area of what you're trying to do?
I can tell you what it was like in the beginning, where I was looked upon, and we still even hear it in meetings now, where people are referred to as patients. And I was part of the movement to shift from someone like me who is in this world of awareness building, advocacy, community organizing, research, etc., of moving away from being called a patient. In our Western society, it was always thought of the patient was passive. You went to your healthcare provider, you received passively whatever your healthcare provider decided to do about your situation. And I quickly realized that that didn't work, because I was told that chronic pain was going to be in my life forever. And I realized I was going to have to find things. Nobody was going to be able to do this for me, fix me. I was going to have to find ways to make my life better, to make the pain bearable, to have some sort of a life. And mind you, Tiffany, in the beginning, it felt very, very bleak. But within my advocacy work, my awareness building, my helping to create and spearheading the creation of resources for people like me, I was seen as someone who, I was a patient. What could I possibly add to a conversation? At times, my presence was not welcome. It was challenged. I was asked to leave meetings, government meetings. I was told I was a complainer, a malingerer, and a drug seeker. and I had no place here in various settings, okay? And I respectfully stayed in the meetings, and I respectfully added to the conversation. And I strove at that time to show that I could model being more than the passive patient, and that I did have a perspective to offer. And several of us were doing this. And over time, we found champions within the Canadian Pain Society. I came to the Canadian Pain Society through Dr. Celeste Johnston, who created the now former Canadian Pain Coalition, and I was president of that. And with that, it became one national voice of people living with pain until 2017. And we did a lot of work in advocacy and awareness building with the Canadian Pain Society, in tandem with them. So that was a difficulty. I encountered, being invited to tell my story and being asked, well, where was the doctor who diagnosed me? And I felt as though my story and my messages needed to be validated by a healthcare provider. So over time, people got to know me. You build your cred, you build your ability to work in less than friendly circumstances and environments. You find your allies, you pull those people around you, and you gradually move forward, and you recognize the strengths of others and bring them and ask to work on their teams or bring them to your team. And then you start to gradually build a movement forward, and you get people interested. And that's how you move things forward.
What is the ultimate hope of what you're doing, the work that you do, and in the landscape of pain in Canada?
Well, first of all, I'm delighted to see that there has been such an incredible shift in thinking on so many fronts. You know, chronic pain is now recognized as a chronic disease. The legitimization of chronic pain, persistent pain, I call it, has made such a difference, because then the person with the chronic pain is not being blamed as not being able to cope well, not being able to move forward. The blame is taken off that person. The legitimizing means that now the system is looking for better ways to be helping individuals. That is incredible. I'm thrilled that now more and more we are having people with lived experience at tables where policy is being discussed. I was several times on Health Canada's scientific advisory committees for different issues like opioid prescribing, opioid labeling, that type of thing, and more. We're moving into a realm where we're introducing our next generation of trainees within the pain space to feel more comfortable to be talking with people with lived experience. We're helping people with lived experience to tell their stories in a way with a purpose to inspire and promote conversations for what can we do next in research, and getting them involved. And so my hope, truly, Tiffany, is that this momentum is going to continue to the benefit of the 1 in 5 people, almost 8 million Canadians, from the tiniest infant who can't speak for themselves to the oldest of our seniors who can't speak for themselves at times anymore. And getting them changing the system, getting them the health care, pain care that they need so that they don't suffer needlessly. And so that people with lived experience with pain are empowered to learn more, to get involved, but learn more from safe, evidence-informed resources so that they don't become a casualty of misinformation, disinformation. And so we have a lot of work yet to do, and I hope I'll be doing some of it with you.
Of course. Thank you so much for your effort, all the work that you do, the passion that you bring in this field. And thank you so much for your time sharing with our audience today.
You're welcome.
Okay, so I'm at the exhibitor hall and I met an amazing, passionate individual.
Tahir.
Yes. Can you introduce yourself to our audience and what you do?
For sure, yeah. My name's Tahir Janmohamad. I'm the founder and CEO of Managing Life. We're a digital health company based out of Toronto that's entirely focused on helping people who live with chronic pain. And we do it through our app-based platform called Manage My Pain.
Continue to tell us more about your platform.
It was first started as a simple way for people living with pain to record their symptoms. A lot of people, over 50% actually, of people living with pain will tell you at some point how they've been dismissed by their care team, not being believed. And so we created Manage My Pain as a way to log what they were going through so they could generate reports and take them to their care team to say, my pain is real and it looks like this. Fast forward to today, it's now one of the most downloaded pain apps globally. We have over 125,000 users using it in 7 different languages. And it goes beyond just tracking symptoms. It actually now teaches people how to live with chronic pain using evidence-based pain psychology strategies. And we've evolved our platform to support not only the tracking and generation of reports, but also actually teaching people through a multitude of different ways about how they can self-manage their pain through short contents, more structured programs that we've co-developed with the University Health Network, and most recently Solace, which is a unique AI-based pain psychology support companion that is trained on evidence-based pain psychology.
Yeah. So when I had a chance to chat with you and learn more about the platform, I'm just very impressed about the work and the thought that's gone into developing the whole app and Solace. I just want the audience to understand a little more, like this is not just ChatGPT. This is not just your regular AI. Tell us more how Solace is different.
Yeah, I will say that right now, the general large language models like ChatGPT, Google Gemini, Copilot, they're being used by people. They're being used by people to answer health-related questions. They're being used by people to deal with mental health issues. And they're being used by people living with pain to understand what they can do. Unfortunately, there are massive flaws in the current systems because they weren't designed specifically to provide health-related support, nor should they. But they're being used anyways. And so what that means is that they're built based on publicly available knowledge sources, some of which is evidence-based and some of it is not. And so what comes out of those general purpose chatbots is a mixture. Solace was designed from the ground up to be evidence-based and only using best practices in pain psychology. So the way that Solace works is not actually ask a question and get a response. Instead, it's designed to be a 20-minute interaction used over weeks. At first, Solace tries to understand what you've been living with in terms of pain. And it uses the track data in Manage My Pain to really personalize those first set of interactions. It already knows that you live with fibromyalgia and are on tramadol and have tried physical therapy and got back surgery. It knows that because you've been tracking that. And so once Solace asks about your pain and how it's impacted your life and what you've tried, what you haven't, it starts to create a profile of you. And then it maps you to non-pharmacological interventions that are all evidence-based. And again, we work with clinical pain psychologists to train Solace in how it operates. And then what Solace does is it builds a plan for you. It says, over the next 7 days, here's what you should focus on. I'll give you some examples, activity pacing, cognitive diffusion, progressive muscle relaxation. These are some of the things that come out of Solace. And it actually teaches you a specific set of skills for that week through a conversational text-based interface. And it also builds a long-term plan over the next 3 to 5 months. Here's what we're working towards. And I think what's unique about Solace is because it's embedded within Manage My Pain, which is our platform, it has access to the information that you've been tracking in your app on a regular basis. And so it has the ability to remind you about these strategies when you're really struggling, when you have that 10 out of 10 pain flare up in the middle of the night. Instead of going to the ER, taking that second oxy, maybe you can talk to Solace and it can remind you about the strategies you've been working on. And it uses that track data to also update the plan the next time you interact with Solace. And I think what's really exciting about Solace is that we've gone through clinical validation studies. We've co-developed it with leading experts. We've defined a whole safety framework about it. And here at the Canadian Pain Society annual general meeting, I think there's 3 posters that talk about the development of Solace and the safety that goes into it. We've tested it for bias, for stigma, for high-risk scenarios like suicidal ideation. Solace does not do treatment. Solace does not do diagnosis. Solace will not make recommendations to your prescription. It will always defer to healthcare professionals. But it will provide the support to people in real time when they need it. And again, using evidence-based strategies. The last thing I'll share with you is there was a study done with 175 people that showed that after a single 25-minute session with Solace, there were clinically significant improvements in 5 different domains. And people also said Solace was something that they trusted, they found it usable, and something that they would be willing to use continually as well. So there's some really exciting promise to Solace.
Wow. One other thing that I remember you saying is, when we use large language models, prompt engineering is so important because it gives you what you want. But Solace is almost like your pain psychologist that's with you. It's guiding you, not you guiding it.
Yeah, I think the term is called the sycophantic nature, where large language models were designed to be agreeable. That's what they were designed to do. So that is dangerous in certain scenarios. So for example, if someone is scared to move and they say, it feels better when I'm resting on my couch because it doesn't hurt, maybe a large language model will be like, that's a great idea. Mm-hmm. But as you know, that's not a great idea. And so the large language models do need to push back a little bit. And so Solace was designed to emulate what a pain psychologist will do. And so an example is if a patient says, I'm not going to do that because of X, Y, and Z, there's a component of Solace that was designed specifically to gently push back on that and understand why they're reluctant to do that and really try to guide people in the right direction. Solace was designed to actually guide people and structure the conversation as opposed to respond to questions, which is what most models do, right? You ask a question and it responds. Solace is different. It takes you down a specific structured conversation per session. And that's what makes it very different, I think, than the typical chatbot interface.
Yeah. And the other very important component of your platform, Managing My Pain, is that tracking feature. How is this tracking feature important and unique compared to, patient may have a pain journal themselves or,
right.
By memory?
Yeah, I think at the very core of our tracking approach, every pain questionnaire is negative. How much pain are you in? What can't you do because of pain? How much interference is caused? Negative, negative, negative. At 8 p.m. every day, our app prompts people to reflect on what they did in their day that was important and meaningful. What did you do? Focus on accomplishment, on achievement. Because many people living with pain sometimes forget that they're able to still do stuff despite their pain. And it's important to write that down and reflect on that and remember that. And so that's the first interaction with Manage My Pain, is that positive reflection. Then we ask people to reflect on their pain in that moment, not over the past 2 weeks, not over the past month, like right then in that moment, how do you feel? And so people aren't trying to remember things, right? They're recording how they feel in the moment. And I think that makes it very different than the traditional ways of capturing someone's pain experience and symptoms, because it's recorded at the time of experience. So I think that's the biggest difference between our approach and the traditional ways. The second thing is it's really quick. It's 45 seconds in and out. There isn't 30, 40, 50 questions. There's no battery of questionnaires. The idea here is that someone can quickly record what they're feeling and then just get on with their day. And I think that's what makes it so engaging and compelling for people to use.
Yeah, this is really amazing. And you showed me a sheet of how the platform can just generate a summary of data over, the last period of time and see how things has changed. And really see, even though week to week there might be, or day to day there might be fluctuations in pain, over time, how has it changed?
Yeah, I think that's one of the biggest elements is it's one thing to record what you're experiencing, but there's another way to communicate it with a clinician. We worked with the multidisciplinary pain treatment center at the Toronto General Hospital called the Transitional Pain Service. And we actually co-designed these reports so that they are intended for a clinical audience. And so it's framed in a way that is intuitive for clinicians. It shows you your pain score over time, your functional score over time. It shows how key elements related to pain have evolved. And it really becomes that language that is common between someone living with pain and their care team. And it's not just some tech company that developed this in isolation. I'll say that our academic and clinical partners have been core to how Manage My Pain has evolved over time and will continue to be. Without that domain expertise, we wouldn't have built something that is so powerful, I believe, in terms of the impact it can have both clinically and from a user satisfaction perspective.
Yeah, this is a part of why I really appreciated your work, because you really bring in a team of professionals. It's not just you with some computer engineering knowledge trying to concoct something for the clinical population. You really get into the field and have the expertise to chime in, and you've any patient partners.
Absolutely,
as well too,
yeah.
right? Yeah.
Another presentation at this conference was how our program was developed. So the program, as I mentioned, is a structured course, essentially. It's 4 15-minute modules that goes through acceptance and commitment therapy, and it teaches people self-management skills. So the development of this program was an 18-month-long research collaboration. And the key clinical investigator for the study presented today how it involved 7 sprints, where it went through several rounds of pain psychologist feedback, iterating with patient feedback, back to clinical psychologists, and went through 7 rounds of this feedback. And it involved clinicians, it involved patients, it involved developers, us, to guide the UX and UI. And it's this multidisciplinary approach that is absolutely essential. Each one of those stakeholders can't build something independently. They really need the guidance from the other stakeholders. We couldn't build it without our clinical or patient partners. Likewise, the patient couldn't build it without the clinical expertise or the technical knowledge. So I think that is an essential part of building truly impactful digital health solutions.
Mm-hmm. What are the challenges you face in your work?
There's a couple of challenges. Number one, it takes a lot of time to do research, many, many years. So we completed our Solace study in August of 2025. It was just published in March of 2026. That's really quick. That was the quickest study
I know.
that we've done.
It's really fast.
It's very fast. But our previous clinical study was over a period of 3 years. And I don't think it's common knowledge how long it takes to generate clinical validation in the proper way in a controlled study. And most digital health applications and solutions out there have not gone through that rigor. But because technology evolves and adapts so quickly, is it even possible to use those traditional models of clinical validation when the technology has changed in a month? So we face that as a challenge. It's just the speed of innovation, especially with AI. The second, I think, obstacle is funding. Yes, most of our users can go to the App Store and download the free version. Then we have a subscription version that they can pay out of pocket for. But many people living with pain are challenged socioeconomically. And so that's not the best way to reach the people that need it. And so the ideal way is to get it covered as part of chronic pain care or by the insurance companies. Because ultimately, if you can help better manage pain, you bring down healthcare utilization costs. You reduce disability prevalence and disability duration. So there is a natural financial incentive for the payers to actually cover solutions like ours. And that's where we're seeing a lot of traction, is on the payer side of things. We've partnered with Unum, one of the largest group disability carriers in the US, where they've included our solution within their Care Hub offering. We're speaking to other carriers as well to hopefully get this covered so that more people can access it.
Mm-hmm. What is the ultimate hope in what you're trying to do?
I would love to get Manage My Pain and Solace into the hands of everyone living with pain globally. I want this to be the resource that people can use, because the vast majority of people in pain are not getting any care for their pain. We actually are part of Self-Management Ontario. It's a remotely delivered support program for people living with chronic conditions. We have a chronic pain program called Progress Over Pain. Our solution is part of that. So if you go through that program, you get a subscription to our solution. And we had a question once people completed that program where it said, did manage my pain help you better communicate with your doctor? And over half of the people said, what doctor? I don't have a doctor. That's the reality we're dealing with, is most people with pain aren't actually seeing anyone and getting zero care. So it's not feasible to have multidisciplinary pain treatment for everyone with pain. It's 20% of the population. A scalable digital technology can help close that gap, and that's my goal.
Wow. I truly wish all the best to your effort, and thank you so much for all the work and effort and passion that you bring into this field. All the best, and thank you.
Thank you so much for your time.
Okay, so I'm here with Kelly, and it was very nice meeting you and chatting with you after the symposium. Can you introduce yourself to our audience? Where are you based and how are you connected to the pain world?
Thanks for chatting with me today, Tiffany. My name is Kelly Shinkaruk. I'm an anesthesiologist and chronic pain physician in Calgary, Alberta. I do both types of work. So I work both in the operating room as an anesthesiologist and also at a multidisciplinary or interprofessional pain program where I work on a team. And that's what brought me to this conference, because I was presenting a symposium on that topic.
Tell the audience a little bit about the chronic pain program, because it is, I think, the country's largest chronic pain program. Is that correct?
That is correct. So the Calgary Chronic Pain Center program has been around. It was established about 25 years ago. It started out as allied healthcare only. So there were actually no physicians in that program initially. And it wasn't until, I think, 2 or 3 years into the program's existence that they decided they did need to have physicians for diagnostics and for, medication management. So when I joined the group in 2010, it had already been very well established. So we serve about 2 million patients in all of southern Alberta, primarily Calgary. And it is a very well-funded program through the public health system. So everything that we offer is free of charge for patients once they are referred and once they're brought in. I guess a little bit more detail about what our program entails. It is a 1-year time-limited program. And when they come in, patients will be assessed by a physician and a physiotherapist as well as a nurse on the team. And then they are involved in a team approach. So there's physiotherapy, occupational therapy. We have exercise clinicians or kinesiologists. We have psychologists, pharmacists, a social worker. So patients will be offered access to all of those individuals depending upon their needs. We also have groups. So there are a set number of groups that patients are generally encouraged to participate in. But in some cases, some patients, they have a preference not to participate in groups, so that there's no pressure to do them. We do feel that they supplement the rest of the program very well, though.
Yeah. So as an anesthesiologist, what brought you to chronic pain care?
Well, that is a great question. It sounds like I'm being interviewed for research or some sort of a school program. So when I was in anesthesiology, I knew that I didn't want to be stuck in the operating room all the time. That sounds terrible, but I really didn't want to have to get up every day and do the same thing day in and day out. And so as a kind of a mid-level resident, I started investigating different options. And at the time, options for anesthesia were intensive care unit, which is just essentially anesthesia out of the operating room, or pre-assessment clinic, which is kind of a very run-of-the-mill type of clinic. And then chronic pain came up, and it turned out that actually my program director at the time, who was also a great mentor of mine, she was a chronic pain physician. And so I spent some extra time working with her and going to the clinic. And then I did, the rotations that were part of my core program. And I thought, what? I think that I can really do this. And that's kind of what brought me to it. I have family members, as many of us do, that have had chronic pain diagnoses in the past. And so that was also, sort of a compelling reason to come into the specialty to see if I could help them or people like them. Mm-hmm. And ultimately, my practice has grown quite a bit because as many anesthesiologists going into chronic pain do, there is a lot of intervention involved. And yet I actually have a very small interventional practice. I don't do, epidural steroid injections and facet joint injections like a lot of my colleagues. I leave that for them. I do a lot more counseling, medication management, and just working on kind of quarterbacking an interprofessional team. So more on the holistic approach to managing. Absolutely. I think my experience having worked in the interventional space was that interventions are just a very small part of pain management. Not to discount them. They can be very useful for some people. but probably only about 10% of patients with chronic pain. So the remaining 90%, I wanted to make sure that I was aware of other techniques to address that.
That's wonderful. So let's shift gears a bit to talk about the presentation you did at the symposium. So the symposium is focusing on why people fail interdisciplinary pain programs. So tell us a bit about the research that you did.
Yes, so this was an interesting topic because I know that most of us who work with pain using a biopsychosocial model and with cognitive behavioral therapy in mind, or pain reprocessing therapy, or acceptance commitment therapy, we are always trying to make things more positive. And so the idea of talking about failure seemed a little bit counter to what we usually try to do. But at the same time, it's something that is a very important topic because we all encounter these patients that appear to be working through the program, do their appointments, attend groups. They seem to be invested, and yet at the end of the program, they just haven't improved. So the research that I did kind of a two-pronged methodology, vaguely mixed methods. So I did a chart review where I just looked at 100 charts for the most recently re-referred patients to our program, so patients who had already been in the program. And I wanted to look to see what percentage of those re-referred patients appeared to have failed the program initially, so that I could kind of find out if there was any common elements, common factors. And so I did find 18 of those 100 charts demonstrated patients that I categorized as having failed the program. And common things between those patients were various complex medical conditions, so not just pain, but occasionally painful conditions such as rheumatoid arthritis, other autoimmune conditions, patients who had extensive or multiple surgical interventions, patients who were on chronic opioids or had significant polypharmacy, sometimes seeking advice for changes in medications. Also patients with active psychiatric disorders that were currently under-addressed. So those are some of the things that I saw in the chart review. And then I did a survey where I sent a questionnaire around to the staff people at our program. And I had a response rate. It was quite reasonable, actually. We had an N of 36. And the questions were really surrounding how the practitioners would categorize people failing our program. And then I asked a variety of questions about what types of factors they detected in a specific patient. So I had on the questionnaire, I asked the participants picture or imagine a patient that they had in mind that failed the program. And then the questions were pertaining to that patient. I also asked for them to volunteer, if they were comfortable, volunteer information about that specific patient. And then I did a content analysis to look at what types of themes came out. So ultimately, and I think all of these themes were pretty congruent with what has already been reported in literature. And as we've kind of chatted about, there was no surprises. There were no surprises, but it did kind of allude to things that we could potentially change in our program. So a quality improvement type of approach. But some of the themes that came out were patient-related factors. So patients who came with expectations that were not matched by the program. So patients that were coming with expectations for cure or a magic bullet, some sort of an answer that they hadn't yet gotten from all of their other previous encounters with healthcare. So those patients tended to do poorly, and that was actually one of the highest rated factors. I think essentially every one of the respondents listed that as a reason why patients would fail. And then it went on to things like patient psychosocial elements. So if they had a lot of psychosocial stressors in their lives, financial stressors, lack of support system. And that also came up in a lot of other contexts during the symposium discussion about patients that don't have a lot of social supports really struggling because they don't have enough space left in their tank. Like they're just kind of overwhelmed. The bandwidth, exactly. So the bandwidth is exceeded in technical terms. And then the other one was about the psychosocial sort of triad of pain catastrophization leading to fear avoidance, and then low self-efficacy, and how that all kind of blends into one another. So they're all kind of mutually related. So these have all been reported quite extensively in the literature, and even going back to like the 1990s when biopsychosocial models were first sort of being discussed. That's even further back into the 70s. Then there were sort of systemic issues, so concerns where patients were involved in some sort of a system that was challenging. So In Alberta, we have the Workers' Compensation Board. So that's patients that are off work for some reason. They've been injured at the workplace. And there's an expectation that they will report their deficiencies, their disabilities. And it's kind of in stark contrast with us wanting to help them get better. So if people are entrained in or entrapped in WCB or litigation or disability, that can be an overwhelming factor.
Because they kind of have to prove that they continue to experience these disability to continue to receive care.
Exactly. So that really kind of goes back to yellow flags. So when we talk about yellow flags in the literature, and in my study, perceived injustice wasn't specifically mentioned, but it was something that came up in some other parts of the symposium talk. And I thought, yes, that is really true. Perceived injustice is really that psychosocial element that is coming from these areas where the system has done people wrong, is a disservice. And then the last one was really more of a programmatic issue. And it's where our program is supposed to screen for people that we think will be successful in the program. And that would be excluding people who have things like active substance use disorders or active acute psychiatric conditions. And of course, we want to try to help all those people, but we do know that they don't necessarily do well in our program when they have all these other factors going on. So there was a lot of discussion about whether we need to triage people better, whether we need to be a bit more adherent to our exclusion criteria, whether there need to be repeated triage points. Also in the program area, we talked a bit about goal setting and how it should really be an iterative approach where all of the providers continue to speak to patients about goal setting and whether they're achieving their goals, and how that we sort of weren't doing that as well as we could have. It ultimately led into the last theme that I found or that I determined, and that was about disengagement. And really, when looking at that theme, disengagement is kind of like when the patient is no longer really participating, they might show up, but they're not really engaged. And how that's really a downstream consequence of all of those upstream issues. So it's sort of the first 5 themes or factors sort of lead into disengagement, but it's disengagement that we tend to see when we sit in our interprofessional meetings and we say, oh, this patient is struggling or this patient isn't doing well. And the issue is once we have a patient that is disengaged, it's hard to get them back to being engaged. So it's something that all of those other areas need to be addressed so that we try to prevent disengagement. One of the respondents actually mentioned the fact that when we see a disengaged patient, our knee-jerk reaction is to try to get them more engaged, offer them more appointments, offer them more groups. But in fact, once they're disengaged, the likelihood that they will embrace all of those resources has declined significantly. So at the end of all of this, we can see why patients may fail these types of programs with all these resources. But the big, compelling question, and perhaps the next research project, is to start working on how to address those issues upstream so that we can offer different types of programs to help people that have these vulnerabilities, have psychosocial stressors, things that don't work in our program, but they still deserve treatment.
That is a very comprehensive summary.
Yeah, sorry.
I'm very impressed that you did that without any notes in front of you.
It's the brain. It's all in there.
So it just really showcased the biopsychosocial model is not only how we conceptualize treatment planning and understanding of the whole person factors, but also these factors do actively play in why someone may fail, because biologically, complex medical comorbidities, issues can be a reason why they don't do very well. Psychologically, we've spoken tons, if they have active under-addressed psychiatric disorders, etc., or rigid personalities.
Absolutely.
Perceived injustice. And then socially, big time is that they just have too many stressors going on in life, or they put themselves at the bottom of the totem pole, so they are caring for this and that, putting out fires in their life. They have no resources to put out their fires in their own life. So I think this research is really important to continue to help us better utilize the resources we have in interdisciplinary pain program and see what we can do better. But ultimately, we have limitations, patients have limitations, the system have limitations.
You've summarized it amazingly well. I think at the end of the day, we do have to keep in mind that we are stewards of the healthcare resources that we have, and recognizing that we can't necessarily help everybody with the programs that we work in. Which patients can we help? When we have a waiting list that's over a year long in our center, for sure, is there a way that we can best screen out patients that will truly embrace and utilize the resources, and then try to help with systematic approaches to address the patients that won't do well in our program? I mean, I think, there's always going to be some failures. And one of the things that came up that was an amazing point that somebody brought up during that symposium was that sometimes we see people who have presumably failed a program, and yet we have planted the seeds for them to improve once the setting is correct. And so that would also be a really interesting research project to look at, exactly what types of stressors or factors need to minimize in order for a patient to then start to utilize the things that they have learned. So, I think we have to be careful not to throw the baby out with the bathwater, yes. Right? So patients might appear to fail, but perhaps they have been given enough tools that once they're able to put them into practice, maybe they will start to do better. That's a longitudinal study that it's going to be hard to structure, but would be really interesting to look at.
Yeah, when the seed can finally meet a good soil and someone who waters it.
Oh, yeah. That is a great analogy. I'm going to use that one.
Yeah. Thank you so much for sharing this. I hope the audience found a lot of value in this research, and think about maybe doing some similar types of research if you're in a similar setting to analyze, and as a way of quality improvement as well.
Hey, the interviews are over, but don't go yet. Hear me out. Paincast is a freely available resource for you. For each episode, I dedicate hours of research, coordination, writing question outlines, and editing. And truly, nothing for you without you. To help me make this resource even better for you, I want to hear from you. Connect with me at paincast.psd@gmail.com. If you appreciate this podcast, give us a rating on the streaming platform you're using and share with others about us. If you have Instagram, check out our page at paincast.psd, where you'll find bite-sized knowledge in 1 to 2 minutes. Thank you for supporting Paincast, and stay tuned for future episodes on pain and physiotherapy.